Good morning. Thank you, Dr. Rashanjani. Hopefully we'll get off to a nice, slow, easy start at 8 o'clock in the morning. I apologize if some of this is beneath some of the audience because many of the people in the audience are well-versed in minimally invasive surgery, and almost everyone in the room is well-versed on myocardial protection. So with that, here we go. When in Texas, the title should probably be a little different. Should probably be Pumps, Pipes, and Preservation, or Pumps, Pipes, and Lubrication. I'm not sure which, but I really have no disclosures relative to this presentation, and the objectives, I think, are in your handout, but basically to overview considerations for bypass circuit, overview cannulation, and overview preservation options in the current era. The strategies that are used every day in our conventional surgery are equally applicable in most situations to minimally invasive cardiac surgery. We want to look at reducing cardiopulmonary bypass circuit surface area, reduce cardiopulmonary bypass prime, and for many of us, consideration of adding ultrafiltration to that in an effort to let patients leave the operating room in as optimal condition as we possibly can. If we look at each of these, to reduce our cardiopulmonary bypass circuit area, oftentimes an easy thing to do is to go from 1/2 to 3/8 inch tubing. To augment our venous drainage, I would say we augment venous drainage in every case we do, so it's not unique to minimally invasive. And to reduce the circuit length to only the necessary length. Again, these are things that most all of us do every day in our practice. Prime volume, well, most of us have evolved to low prime oxygenators and arterial filters. I would venture to say there really aren't many people out there using the old oxygenators that required tremendous volumes that we used 10 years ago. We use antegrade autologous priming and retrograde autologous priming to try to get rid of any excess crystalloid or prime volume in the circuit. On pump, if it's a pump case, I don't want to offend Dr. McGinn here who likes to do off pump, but if it's an on pump case, then we employ modified ultrafiltration. Oftentimes, especially structural heart patients come to the OR with a lot of excessive volume. We will actually pull a good bit of volume during the pump run. And then post-bypass, we will tend to do modified ultrafiltration for 10 minutes or a liter after coming off pump. And with that, we've found the results to be quite impressive. If we then move to cannulation considerations, again, it's all about keeping it simple. You can view this as conventional, which we all train to do. Some of us are older than others, but we're pretty well versed at conventional cannulation. And then there are alternative strategies that are useful as we look to do things less and less invasively. We can break this down into arterial, venous, venting, and cardioplegia cannulation strategies. This is kind of a typical picture I borrowed from Dr. Carpentier. It shows that if the hole's big enough, you can put all your tubes directly in the heart. That's the way a lot of us trained. We were conditioned that deviant behavior was bad, and it needed to look the same way every time, or we were just not doing what we were supposed to do. In today's era, this is not exactly the case. So your cannulation considerations are largely dictated by your approach. And over the course of the next 2 days, everybody in the room is going to hear a lot about various approaches. But if your approach is an upper J or T sternotomy versus a lower mini sternotomy, you can cannulate in any number of ways, but oftentimes you can cannulate in a very conventional manner. You may need to use more of an aortic arch cannula rather than a typical J cannula, but oftentimes it allows you to work through that hole and employ your usual techniques. On the other hand, having some of the alternative techniques allow you to make that hole a lot smaller. Not all non-sternotomy approaches are created equal. On your left, you see a thoracotomy approach. That's a rather big incision. You can put a lot of tubes through that incision and still have plenty of room to work. With the current vernacular, that is still a minimally invasive cardiac surgery operation. But it's quite different than the figure on your right, where you have a small, I call it a working port, with a femoral incision, if you cannulate femorally, because you can't get all your cannulation apparatus through that small incision. So you need to have other alternative strategies available. We're all well versed with direct aortic cannulation. Most of us today use diffusion tip cannulas. Works great. And as you'll see when we go through some of the alternative strategies, a lot of the same ideas are employed. It's just a matter of how you get it there. We're all pretty familiar with femoral cannulation. Most of us use that for our redos or other thoracic aortic emergent cases from time to time. But there's some things that we need to keep in mind if we're going to do it and do it safely. 20 years ago, we were taught to free up the entire vessel, obtain circumferential control, and most of us saw a fair number of lymphoceles in our groin incisions. In today's world, we really don't do that. You expose the area of the vessel that you really need to have exposed. That's typically the anterior surface of the common femoral artery. Most of us use ovoid purse strings rather than a round purse string that allows for less constriction on the vessel when you close the purse string. The ovoid is located transversely. We use Seldinger technique to cannulate the vessel. It's important to confirm that the wire is in the descending thoracic aorta on transesophageal echo so as not to be in a false passage. Make sure that we're not setting the patient up for a disaster like a retrograde aortic dissection. We want to do atraumatic dilatations. Most of the kits that we use today have progressive dilators. They have very gentle transitions from the inner cannula to the outer cannula. And if you just simply ram the big cannula in, you're going to create an intimal flap and you're going to create a distal flap issue when you take it out. Inserting the cannula fully. Those of us who've been around a while remember the short femoral arterial cannulas that only went in maybe 3 inches. The cannulas today are designed to go in much further, and most of these cannulas in the average patient sit in the proximal iliac artery, if not the distal abdominal aorta. This lessens the likelihood of the vessel being closely adherent or closely opposed to intimal problems, and reduces, at least in theory, and most of us feel it reduces the likelihood of retrograde arterial dissection on these pump cases. Well, if you really want to go to the extreme, Dr. Cooley had some interesting comments that were quoted earlier about Hartport. Francis Robachek, who was my senior partner at the time, had a number of other interesting comments about it. But there actually is a femoral platform, currently through Edwards, that uses a double cannula femoral endo-arterial system through which you cannulate the groin and you pass an endo-aortic balloon, I don't think the pointer works, but the endo-aortic balloon up into the ascending aorta, which allows you to perfuse peripherally and clamp the aorta endovascularly. It's an alternative strategy for patients where you may or may not feel that it's safe to put an external clamp on the ascending aorta. This is a picture of the endo-arterial clamp. Again, it's a long balloon clamp. It has 3 lumens. One allows you to deliver antegrade cardioplegia. You can measure proximal aortic root pressure and measure balloon pressure. The balloons will typically fit aortas that are less than 4 centimeters, but aortas that are at or about 4 centimeters or greater tend to create issues. There are obstacles that we all run into. Most of our patients today are not pristine, healthy 40-year-olds. They're less than pristine 75-year-olds. And many of their aortas look at least this bad, if not worse. So there are other considerations when we talk about alternative strategies, and this is an example of a endo-direct arterial cannula, three slices down, 24 French, that is a way to cannulate the aorta through the rib cage and achieve central aortic cannulation and still have the ability through that cannula, if you choose, to place an endoaortic balloon. This is a corporate Edwards rendition of what that looks like, and it works very well with minimally invasive approaches to the aorta. You have access to the ascending aorta. Most of us would use a pledgeted or double purse string technique to make sure we had that able to be well secured upon removal, but it actually works very well from an entry point. This is a schematic that just shows the tip diffuses blood out into the body, but there's also cardioplegia delivered into the aortic root. This is an intraoperative picture as well as schematics, as well as an echo picture that show the catheter in position with the balloon in place, achieving aortic occlusion with central aortic cannulation. Well, the ascending aorta is not always pleasing either. And most of us, if we're setting the patient up for a minimally invasive operation, we hope that one of those two platforms is going to work well, and we hope we're going to be able to do it in the usual manner. But occasionally the ascending aorta is bad, the iliofemoral system's bad, and so you need another strategy. And this is an example of cannulation of the axillary artery. It's a technique that we're familiar with our acute aortic emergency cases, but it can be employed in minimally invasive cases. As you'll see going over the next couple of days with patient positioning, unless the arm is up, if the arm is by the side, you can get access to the right axillary artery, and you can either cannulate it directly using the techniques that we discussed for femoral cannulation, or you can attach a Gore-Tex graft. Most people will use a 6-millimeter graft, and either put your arterial catheter directly in the graft and tie it, or you can get creative and use a dry seal sheath, trim off the sheath, put the sheath in the graft, and then put your catheter through that if you think it's going to be a long case and you're worried about leakage around it. If we look at venous cannulation, I think the go-to cannula for venous cannulation is typically a multi-stage 25 French femoral venous cannula for most people. This cannula can be placed either with an open or percutaneous technique. Many companies make a version of this cannula. You want to be able to have a good bicaval view on transesophageal echo. This is of paramount importance in passing the wire up and also getting your cannula positioned appropriately. If you're using an open technique, again, you want to only expose the anterior surface of the common femoral vein. You want to avoid the fatty lymphatic material between the artery and the vein in an effort to minimize the risk of getting lymphatic leak and lymphoceles. Place a large purse string. It's a big vein. You don't have to worry about narrowing it. Typically, most of us would use a 4-0 proline for that. And then cannulate it with typical Seldinger cannulation technique and positioning the tip about 2 centimeters up the superior vena cava. If you're not opening the groin, percutaneous techniques work great. A couple of important caveats are, yes, you use Seldinger technique, but you want a stiff guide wire. You really want a rail for that catheter to go in over. Otherwise, the wire that comes with it will typically kink in the subcu tissue and you'll get really frustrated. So if your initial wire goes up nicely and you get your access to your femoral vein, then you can place a stiff J-tip guide wire. We use an Amplatz J-tip, 180 centimeters. And over that, do progressive dilatations. Use the large bullet dilator that comes with the catheter. Typically leave it in to let the tract dilate, and then the catheter goes in quite nicely. If you look at these catheters, and this is just a representative picture, they're marked such that you know how far out the tip of the catheter the trocar introducer is. So as you pass the venous cannula up, you want to draw that sharp, pointy tip back into it. So that for me, typically by the time I get the catheter up to about the level of the liver, I pretty much have the inner cannula pulled back so the tip is not extended, and then the catheter can simply follow the wire up in a very atraumatic manner into the atrium. One of the things you want to avoid is not having a good bicaval view, allowing the guide wire to get coiled in the right atrium, and then forcing that pointed tip that all these cannulas have on their inner cannula, on their inner trocar, into that atrial appendage, because you can certainly cause a perforation. Venting, you can get as creative if you want. With heart port technology in the mid-90s came the concept of a PA endovent. It's still available. Many people use it for their minimally invasive valve cases. It works. It comes with a cost, but it's very easy to place. Anesthesia typically places it in lieu of a swan and then trades it out for a swan at the end of the case if you want a Swan-Ganz catheter. LV venting is typically a conventional type vent. You can either place it via the right superior pulmonary vein, or if you're doing an atriotomy, place it through your atriotomy and just tie your atriotomy suture once you take your vent out. Cardioplegia cannulation, well, this slide kind of summed it up with you can place it in the ascending aorta or you can place it in the coronary sinus. And for many of the things we do, you have the option of doing either of those through your minimally invasive option, and you'll see people showing both of these techniques today and tomorrow. Personally, I like a long, flexible ascending aortic cardioplegia catheter. Most of my cases across the board get antegrade cardioplegia. I don't use a lot of retrograde cardioplegia these days, especially on minimally invasive cases. The only caveat would be if there's significant AI. But this particular catheter allows you to place it in the ascending aorta, withdraw the needle, then I will typically hook a Y connector to this so that we have aortic root venting as well as cardioplegia capability for my perfusionists. You can also place an endoplege catheter. Again, this is an Edwards product. This is placed through the neck. There are centers that do it very well, and it takes very little time. There are other centers that struggle for considerable amounts of time trying to get it placed. And in reality, as we'll discuss with myocardial preservation, I've found this to be less and less of a necessity as more and more of my cases get antegrade plege. So now moving on and trying to keep us on time to the cardioplegia and myocardial preservation portion of this talk. We're all well aware of the underlying theory. Whether we're surgeons or perfusionists, the underlying theory is we want to protect normal contractile cardiac function, and we don't want to create any irreversible hurdles that we have to try to get over after the case. During arrest, myocardial preservation requires the promotion of anaerobic glycolysis, the prevention of intracellular calcium accumulation, and scavenging of free oxygen radicals. Metabolic arrest is coupled with hypothermia. This gives us simple and rapid arrest. The cardioplegia is typically high potassium based. Potassium washout and myocardiocyte depolarization can be drawbacks of that. So there are other additives to help offset that. And standard cardioplegia, and I put that in quotes because I'm not really sure what standard is today, has polarizing agents such as lidocaine, calcium competing ions such as magnesium, and oxygen and energy delivery during ischemia in the form of red blood cells. The gold standard is our familiar potassium-rich solution. We give it antegrade, we give it retrograde, we give it both directions depending on the case we're doing. In the current era, we're all here because patients want more for less. They want perfect outcomes. They want major surgery through small incisions. They want to return to normal activity. So there's increasing scrutiny of everything we do. Our patients oftentimes are in the elderly cohort. They many times, most times, have multiple comorbidities. They, in today's world, have higher preoperative risk profiles. Patients are living longer. We're seeing problems later in life than we used to. And everybody expects, in the vernacular of STS, a 3-star outcome. So today we're going to talk about 3 alternative cardioprotective regimens, such as del nido, modified del nido, and microplegia. If we start with del nido, we'll start with what studies are out there. There are a lot of studies that compare crystalloid to blood. There are a number of studies that compare antegrade to retrograde. But in reality, when you look at the literature, there's no consensus regarding type or route. People use various recipes, various types, various delivery methods. There's some overlap, but there aren't really any good randomized or prospective studies looking at the 3 recipes that I mentioned earlier. Del nido cardioplegia is a crystalloid blood mixture of 4 parts crystalloid to 1 part blood. The recipe is shown here and it's in your handout. It has been popularized by Pedro del Nido and used at Boston Children's for 20 plus years in virtually all their patients. The plasma light is an electrolyte composition similar to extracellular fluid. Has mannitol in it for scavenging free radicals and reducing myocardial swelling. It has magnesium, which we mentioned earlier. It assists in avoiding unnecessary calcium buildup and aids in ventricular recovery. It has sodium bicarb for buffering and scavenging of excess hydrogen ions. And it has potassium chloride, because that's our old friend, for rapid and reliable arrest. Potassium also is depolarizing, which can contribute to sodium and calcium accumulation during arrest and be problematic with myocardial recovery. Lidocaine is thus added to help buffer some of that effect. It's delivered in a hypothermic manner, and as I said, blood by volume is 20%. Supports aerobic metabolism for a finite period of time and provides nice buffering. Most studies have shown that this type cardioplegia gives reproducible protection for up to 150 plus minutes. As I said, the group at Boston Children's has used it for over 20 years with essentially all of their adult and neonatal congenital cases. And they published the results in 2012 showing excellent results with that approach. Cleveland Clinic looked at del nido cardioplegia and published a retrospective review spanning 3 years comparing del nido and versus Buckberg cardioplegia. With their aortic valve operations, they noticed smaller changes in their hematocrit pre versus post bypass, lower transfusion rates, lower elevations of blood glucose, and no difference in troponin following the procedure. They looked at their mitral valve operations and found similarly lower transfusion rates and lower serum troponin levels. They noticed a cost reduction. Cost reduced from about $225 a case to $28 a case. A lot of that cost change was eliminating retrograde cardioplegia catheters and redosing cardioplegia. So it's not a small change. When they looked at their robotics patients, they found an even greater savings because they were eliminating the Endoplegia catheter. This was presented at Western Thoracic in 2014. If we look at Columbia Presbyterian, they published a retrospective review looking at their, quote, high-risk CABG population with acute MI. These were defined as people with troponins greater than 1 and surgery within a week of MI. They propensity matched these patients. They compared previous whole blood cardioplegia with del nido and had 40 to 48 patients in each group. What they found was no difference in mortality, but shorter cardiopulmonary bypass and cross-clamp times. And the quote from the article is that they've used it for adult cardiac surgery since their introduction to it in 2011. This was published in 2014. People are using a modified version of this. What exactly does that mean? Well, it depends on which paper you read in the literature. Modified versions vary from 4 parts blood to 1 part crystalloid to 8 parts blood, 1 part crystalloid. It's believed to leverage the osmotic and buffering capacity of the blood and minimize myocardial cellular edema. Various recipes have been compared to whole blood, but not compared to each other or compared to conventional del nido. And realistically, there's no, quote, standard recipe, although most people seem to be leaning toward 8-to-1, and there are clearly no randomized trials. The most common, or a version of it, is a 4-to-1 mixture. It looks a lot like the del nido with a flip in the blood to crystalloid ratio. The standard dose with it is around 25 mils per kilogram. It's felt in most papers to provide up to about 90 minutes of protection. And the caveat that usually gets tossed around is redose it at 60 to 70 minutes, but not if you think you're within 20 minutes of removing your cross clamp. And I would say that's probably very good advice. It's the same advice that I use with the conventional del nido solution, except I don't redose until about 140, 150 minutes. Undiluted blood cardioplegia, called microplegia, is an interesting twist. We actually use microplegia, and we'll talk about that in a moment, up through about 2012. It is felt to retain the advantages of blood cardioplegia, but avoid unnecessary hemodilution because you're eliminating essentially the crystalloid component of that. It's believed to help minimize myocardial edema, and the ratio, instead of being 4-to-1 or 8-to-1, is really more like 66-to-1. So it's very concentrated, almost pure blood cardioplegia. So multiple strategies exist and no randomized trials. There does appear to be some cost-effective nature to the methodologies we've discussed. It can eliminate some expensive vendor proprietary solutions, allows a lot of this to come in-house. It can help reduce transfusion rates, suggested to reduce myocardial edema. Typically the higher hemoglobins are felt to improve the buffering capacity. A number of studies, when comparing it to conventional cardioplegia, have shown it to reduce post-op low cardiac output syndrome immediately after cardiopulmonary bypass. That's felt to be relative to the myocardial edema, cellular edema. It reduces hemodilution and potentially reduces the need for a hemoconcentrator. So what do we do with this? Well, I've used the word the KISS principle for years, and it's not what you think. It's really keep it simple for Skipper. And that way no one gets offended, my team's not offended, nobody's offended. But as a surgeon, you really want to keep it simple and think about it in a very logical way and not make it overly complex. So blood conservation strategies for all cases. I would tell you that we use the same blood conservation strategies for our non-Jehovah's Witness patient population as we do for our Jehovah's Witness patient population. Avoid unnecessary cardiopulmonary bypass time. Longer pump runs, if what you're doing is making your pump run longer, then figure out a way to do it better so that you get back to a more normal pump run. Choose a strategy that best fits the patient and the operation you're going to do. Over the next couple of days, you're going to see a number of ways to, quote, skin the cat, but the reality is each of these comes with opportunities for conventional cannulation and or alternative cannulation. So pay close attention. A number of experts are going to show you what they do well, and they do it very well. With myocardial preservation, again, no prospective randomized studies. There are no studies out there really comparing del nido versus modified del nido versus microplegia. There are multiple retrospective studies comparing them with conventional crystalloid and or blood cardioplegia. The data would indicate that these are non-inferior, that they help reduce cardiopulmonary bypass and cross-clamp times, that there's a potential reduction for post-cardiopulmonary bypass low output state, and a potential reduction for blood product transfusion, thus yielding clinical benefit and cost savings. I use the word potential in here because if you look at the era in which these things are being evaluated, there are also other things that are changing. And when we look at our data, we changed multiple variables. It wasn't a one variable switch. So to attribute any of this to one thing becomes very difficult. At Sanger Heart and Vascular, we partially transitioned to Del Nido in 2010. We found ourselves using it for our complex cases that we felt were going to have longer cardiopulmonary bypass runs, and it just seemed logical to consider using it on all our cases. I transitioned in 2010. My partners largely transitioned in 2011, and we've been using conventional Del Nido since that time. Our typical dosing is 20 mils per kilogram, and we will give one dose and go up to about 180 minutes. With the strategy, we've actually seen no change in our myocardial preservation. We have, over this time period, viewed a reduction in complications and mortality, but again, attributing it to pure cardioplegia I think is very difficult. We have seen a reduction in our cardioplegia, cross-clamp times and pump times during that era, reduction in hematocrit, but again, as well as platelet drop, but again, multiple variables were changed. Our intra-op and post-op blood transfusions are exceedingly low, but I think multiple variables contribute to that as well. It is cost effective. Cardioplegia with Del Nido costs about $22 a case. So use what you use well, and always consider there might be something better. That's how we re-evolve and avoid extinction. And with that, I'll try to keep us on time and say thank you.